topics. Um, and I want to add a big, huge thank you to our supporting sponsors, being the National Student Osteopathic Medical Association, as well as Sober is the New Cool. You could peep Matt and Chris's wonderful hoodies for the logo there. And our title sponsors being the Kern National Network for Flourishing in Medicine, who have been a huge help in really promoting our not only promoting our event today, but really because our missions align so well between Mindfulness Cafe and the Current National Network, really being able to work with us to help support wellness, not only in medicine, among medical students and trainees, but just in general. And, they're a fantastic organization, so please check them out. And yeah, I'll pass it off to Chris to chat a little bit about what's to come.
Yeah, thank you, Dr. Foti. And again, thank you everyone for being here. This means a lot to Dr. Foti and Matt and Mindsplit Cafe as a whole. So again, thank you very much. So first, I wanted to give a huge thank you to our incredible panelists for sharing their expertise with us. You guys' insight experience is what's going to make this discussion so impactful. Again, I also want to extend my gratitude to Dr. Foti, Matt, and 610 for putting all this together. Their support and dedication to this mission just means everything to me, so I really appreciate that. I would also like to tail what Dr. Foti said and thank our sponsors, KNN for being our title sponsor, as well as our two supporting sponsors, National Soma and Sober is the New Cool. So today we'll be diving into two powerful topics that affect us in different ways. It affects every one of us in different ways. We'll be kicking off things with two keynote speakers, followed by our dynamic panel discussion. And don't forget, we also have a great special guest speaker for us today, packed with knowledge and some great insight as well. So to start, we're going to talk a little bit about substance use and recovery with our first keynote speaker. Now, I could stand here and share all the war stories, the chaos I lived in, the reckless choices I made. I could probably even make you laugh with a little bit of the things that I did. But the truth is, addiction is more than just stories. It's not just about what happened, it's about why it happened and the toll that it takes on every aspect of life. And I couldn't think of a better person to break this down than Mr. Justin Wolf. Justin, you there?
I'm there. Well, thank you, Chris. Appreciate you having me and this opportunity.
Yeah, absolutely. Let me get your slideshow up and running.
Gotcha. Thanks, everybody, for being here. Okay. I appreciate it. And this opportunity to kind of talk about substance use disorders. And there's really kind of three key areas when we're talking about this. Especially one of the things I want to kind of have everybody just kind of keep on the forefront of their mind when we're talking about substance use disorders, the disease of addiction, is that this is a disease that does not discriminate who it impacts and who it affects, especially when you're talking about the opioid crisis that we find ourselves continually and still presently in. The numbers have gone down this past year, which was nice to see. However, this is a disease that impacts families, loved ones. I mean, these are individuals, brothers, fathers, sisters, mothers, significant others. And so that's something that the way in which this disease has been talked about, it is kind of ripped away people's humanity and individuals with this disease. And we're going to kind of talk a little bit about stigma, recovery, and what is a substance use disorder, right? Because I think that's really important as we're kind of talking about this and really looking at it, is just how do we talk about those that are impacted with this disease? And so, first and foremost, when we're looking at the disease of addiction, we are talking about a chronic and progressive disease, just like diabetes, depression, hypertension, any other chronic medical condition that one may experience. yet historically, when we talk about substance use disorders, they have failed to be included in that discussion. And the way in which they've been talked about and the language used to describe individuals afflicted with this disease is so different than we would use to describe other people suffering from other chronic illnesses. And so, what we know about this is that people's own personal opinions and experiences firsthand with others who are struggling and caught up in the day to day battle with it influences the way in which they're going to talk about and interpret those behaviors that people are displaying. And so, when we're talking about this diagnosis, first and foremost, we need to recognize that, hey, not everybody that drinks has an alcohol use disorder. Not everybody that smokes has a cannabis use disorder. This operates on a spectrum. You have individuals who are abstinent, and you have individuals who are highly engaged in their active use. And so people are going to fall along that continuum. And what we know is that, just because somebody is living a life of recovery doesn't mean that those symptoms can't reemerge at a later time, under distress, in a high risk situation, on an anniversary, triggered by their own mental health diagnosis and an escalation of those symptoms. Because when we're talking about this disease, it is a biopsychosocial disease. And so what we know, just like other chronic diseases, is that I think it's really important for us to be aware is that this disease, just like other chronic diseases, can be managed, especially when people are receiving appropriate treatment that is assessing and addressing their holistic needs. This can even be managed during very high risk times, such as pregnancy. And I've worked in settings where we have worked with individuals in a residential and an outpatient setting who are pregnant, and they're managing that, and they're going to the clinic, and they're doing what they need to do to really maintain their recovery. And I also think that it's important for us to also remember that just like it takes incredible strength, fortitude, support, resources, willingness, honesty, and just being open to kind of other people's suggestions to enter into a recovery lifestyle, it doesn't mean that an individual is necessarily cured. And I think that's important for us to remember. I've worked with numerous people who have sustained long periods of sobriety under their belt, and they have gone, for example, to the hospital. And I also co-facilitate this NAMI dual diagnosis support group. My co-facilitator is very open and honest about his struggles with opioids and kind of where it got to with fentanyl. And he had a major surgery, and this is just kind of an anecdote, right? And he, at this point, has celebrated 5 years sober. And it's a huge testament to the lifestyle changes and him actually addressing those core factors that were driving his use that he wasn't even aware he was suffering from, ironically enough. And so I say this all with, he went and he got some infection in his shoulder, which led to an abscess, which like also now he's got a tube running into his shoulder, pumping antibiotics. And when he's in the hospital, he is grinning and bearing this. He is dealing with this without using any opioid pain pill because he knows how his mind works. The idea that one is too many and 1,000 is never enough. Meaning that once he starts, he knows that is going to activate a part of his brain that he has been able to manage through lifestyle changes, that the risk of going back there is not worth it. And so this individual had a conversation with his attending who's like, hey, I really think you can manage this. Here's a prescription for 3 days. I'm not going to refill it. There's no refills on it. Or how about while you're here, I can see how much pain you're in. And he's having the same conversation over and over again with his attending saying, hey, I'm sober. I'm living a life of recovery. I do not want any pain pills. And he tells this story with the intention that he goes to the pharmacy to pick up his medication that day when he's discharged from the hospital after being in there for 72 hours. And what is also attached with what he has to pick up is a prescription for Norcos. Even though he has been blatantly open and honest, that prescription was still there. Unfortunately, he made a choice. He's like, I am not filling that prescription. Please discard that for me. And so that's one of those things. Even though he's been doing everything he's needed to do to put himself into a life where he is finding meaning, purpose, a sense of direction, that was something that was unexpected that kind of showed up on his doorstep, that if he wasn't prepared and been doing what he needed to do, it could have been a very different story he'd be telling when he's talking about that experience of having those Norcos unexpectedly waiting for him. And I think that's the thing when we're talking about substance use disorders, right? Like, this is a chronic and progressive disease. This is something that when we enter recovery, it doesn't mean that the disease is no longer present with us. It is carried with us and is influenced by the choices that we're making. And I think when we look at the way that we treat this and we're serving those that are impacted by it, it is no different than any other chronic illness, right? We want to help reduce the symptoms that have reached a problematic level. We also want to help people improve their psychological, their physical, and emotional well-being. That's the part, right? Helping people reintegrate into society and help them feel like, hey, I'm waking up today, my eyes open, and it's not the first thought of like, oh, dear God, I woke up. It's, all right, I have the opportunity to kind of do something different. And that is what makes it worth it. And I think that's so important when we talk about living a life of recovery, is really connecting with that sole purpose of what is it that I'm going to do with my time on this earth that's going to make my life and my time feel like it's actually worth it. And that's when we talk about people's values, right? And really connecting and showing up as the person that you want to be showing up as. And I think one of the biggest things that people start learning very quickly is that, hey, I need to change my playgrounds, my playmates. I need to start building some boundaries with other people. I need to stop associating and going back to the same places that set me up to kind of fall into that lifestyle, right? If I want something different, that also means my behavior needs to start looking different as well. And that relationship that I'm forming with myself and others has to look different. And I think that's when we're kind of looking at, really, when we get to that place, nobody's having a good time when their disease is in full-fledged, full force, taking control, dictating the actions and the behavior. And I think that's where a lot of that stigma that has been projected and perpetuated throughout our country really has kind of given a misperception of what it's like for an individual to be living and carrying this disease with them. And it starts kind of back here, right? Like the Just Say No, or the War on Drugs by Nixon, right? Like, we're going to have a war on drugs. Or, you know what? Like, I guess for those that didn't have the ability to say no or just say no, they must have A, missed that memo that went out, or B, I must not be strong enough, right? Because that's when we start that inner critic and that self-judgment and that blame and that shame game that starts taking full throttle, where it's like, other people can do this. Why can't I? And that's also led to a lot of really stigmatizing beliefs that have been perpetuated throughout our country that have been carried out through the helping profession, even, where it's like, you hear it all the time. And I've been in some pretty non-client centered conversations that people are talking about, hey, this client's too much. They don't want it bad enough. They're never going to change. Or, you know what? They just need to hit bottom. Never have I ever seen anybody be told, hey, you just need to hit bottom, or, you know what, which is pretty much just saying, hey, you know what, you need to just go out and keep using. Like, that's not fostering a sense of connection. That's not fostering a sense of like, I'm acting in your best interest here. That is stigmatizing beliefs that we have taken a step back and lost a lot of people to this disease due to the stigma attached to it. Slide. And so that's where you've seen a big shift start to happen in the way that we treat those impacted with this disease. There used to be these old school mentalities of like, hey, I got to break them down. It's going to be a full-fledged confrontation. And I've witnessed many of these confrontations happening. And I'll tell you what, they are very uncomfortable to watch. Where the idea is, I'm going to break you down. I'm going to make you feel so bad so that now I have the ability to build you back up. And what we know is that a lot of times when people are entering treatment for substance use, nobody is coming into treatment on a winning streak. Nobody is like, hey, my best days led me here. Absolutely not. And so what we know is that attack therapy style made people feel worse. And it reinforced a lot of negative self-beliefs and judgment and shame that individuals carried. And what we all know about the field of trauma and substance use is that these two go hand in hand together. And so when somebody has experienced trauma, that attack, that blatant in your face confrontational style of trying to convince or coerce somebody into changing is not effective. And it actually makes people feel stuck and go backwards. And so that's why we've kind of moved and shifted away from that frame of working with clients as opposed to attacking clients. So next slide. And so that's when we're talking about like stigma, right? There's this idea that people are flawed, they lack something. And that's the degree of stigma is always attached to how much is the individual to blame for their condition or their situation. The way in which we blame or the stigma attached to mental health diagnoses, the most stigmatized disorder in our country is a substance use disorder, followed very closely behind schizophrenia. Those two diagnoses together are highly stigmatized. And that has led to the people that are afflicted with that disease are treated very differently by those in the helping field. And also, that stigma can become self-stigma, internalizing that external stigma to the point that now they find themselves saying those very same things to themselves. Next slide. You all are about to watch me talk faster than I was already talking. It's going to be fantastic. But the reason why stigma is so important for us to focus on and be aware of is because guess what? This is what is stopping people from reaching out and getting help. This is what is contributing to those increasing overdose rates, suicide, shame, judgment, people feeling like they're a burden that the rest of the world would be better off without them. And this is impacting families. This is where you're seeing kids being raised by grandparents now. And that's why their loved ones and their significant others are no longer present, is due to that internalized shame and that stigma that has led and further fed the disease of addiction that they found themselves caught in. And our communities are feeling that pain. Next slide. And so that's when we talk about shame, right? That's where like, hey, it's not what I did is bad. It's there's something about me that's bad. And I will tell you, this is one of the most common conversations I have with individuals who are struggling or entering early recovery is the shame that they are carrying about the choices that they made, the fact that, hey, I sold myself short and I sold others short, and I feel like that's something bad about me. And that's also what leads people getting to the point of thinking about ending their life, taking their life, suicide attempts, overdoses, and using and thinking, you know, if I don't wake up tomorrow, so be it. It was a nice run. I'm okay going out like this. And I actually had a conversation with a client today about that very thing today. And so it's a very common belief that people carry. Next slide. And so I heard this quote and I loved it. And I always think that it's like really important for us to remember, right? It's like an individual with a substance use disorder needs shame, like an individual dying of thirst needs salt water. And so I thought that just kind of captured it beautifully, much more articulately than I could have shared. All right, next slide. And so that's where we kind of moved away from like, hey, change motivated by discomfort. That confrontation can't happen between the helper and the client. That confrontation is internal. The person looking at the choices they're making, the behaviors in which they're engaging in, and seeing how does that align with the person that I want to be. And that confrontation where it's like, hey, I'm not living the life I want to be living, and I'm not showing up the way I want to be showing up. Like that confrontation makes it really hard for one to sit with oneself. And so that can help kind of drive people towards doing something different themselves. And so what we know about this disease, it's not a moral failing. It's not a matter of willpower, because I've seen a heck of a lot of people, just like everybody else. And again, I don't think I'm unique, even though I said that earlier, that like, it's not that they just didn't want it bad enough. I've seen a lot of people really want this and make significant strides and changes only to lose themselves to this disease. And I think that's when we're talking about what recovery is and how people can move forward. This is not a character or personality defect. This is a chronic and pervasive disease that impacts the entire person physically and emotionally, mentally. And so the way we talk about people with this disease matters. It is significant. And so the way in which we want to talk about individuals impacting like this is no different than the way we talk about individuals impacted by other chronic diseases. We see the person first. We want to use person first language. They're not abusing something. They have a substance use disorder. They're not an addict, which is something that I've heard thrown around by the most astute professionals talking about somebody in that manner. And it's like, you would never talk about your family member in this derogatory manner. And you're kind of losing their humanity and their person first. And I think this language is really important, and people feel that. And the way we talk about individuals matters, because the way we talk about people, you think when we run face to face, if we're going and we're talking negatively about somebody, then we come face to face with that person, so that individual doesn't feel it in that interaction, that we're really good at faking it, that I can cover up this stuff, that stuff comes up and that stuff comes out, and it interferes in building that alignment and that connection in that relationship. So that's the way we talk. It's really just critical. And there's been a big shift on that. And we want to look at people's strengths, find out what people are doing well. I think a lot of times as helpers, what we do is we become deficit detectives. We find and highlight what's going to go on their treatment plan. What are the things that we're going to work on? What do I need to build them up in, versus saying, hey, you know what? Their track record for getting through horrific days is 100%. They're still here. They have found a way to navigate and get out of bed on days that they thought they would never see another sunrise, and they're still here. Let's pull on those strengths. Let's look at what they've utilized, what they've been pulling on to empower themselves, and how do we support them on that journey. And so really, people are much more well attuned to respond to somebody highlighting things that they're doing well, versus somebody who's like, hey, I got a problem list of all your issues. Where do you want to start? Because this is going to take a while. Like, that's not engaging. So that's where I'm like, hey, that positive and strength-based approach is really engaging on the front end, because we can also find a way to engage with them that doesn't just repeat their own inner dialogue that they have going on, where they're picking themselves apart and really highlighting those areas that are not meeting the standard. So what we can do from a public health perspective is just really recognize that a lot of individuals, when they're reaching out for help, it is most often not for their substance use disorder. It is due to another health concern. And there's a lot of research that shows, like, hey, when individuals with a substance use disorder make contact with the medical system about a chief complaint, and that individual finds out that they have a substance use disorder, all of a sudden now their chief complaint takes a backseat, and their substance use becomes the primary focus of that interaction in that session, where they now have had a negative interaction with the helping field. And so really recognizing that when we hear what people are really carrying with them that have led them to reach out in that moment, and we can attend to that and start building that trusting, that foundational relationship, that helps us create the space to actually work on these other areas of concern that we're recognizing might need some additional attention. And so what we can do is start to look at recognizing and screening for these disorders in our primary health setting, and knowing what our next steps will be when an individual presents with a primary substance use presentation, and to be effective and efficient in our care. So thanks everybody for listening to me. Appreciate the stage. So thank you all.
Yeah, thank you. That was great, Justin. I knew Dr. Weiner told me you were great, so I'm so glad that you were able to join us. I truly appreciate it. And I know you're going to be sticking around for the panel discussion, so thank you for that as well. Next, we have Dr. Foti is going to say a couple words. Dr. Foti, are you ready? And after Dr. Foti, we have our special guest, and then we'll kind of roll into the panel discussion right after a quick little shift around. Dr. Foti?
Yeah, and I just want to echo what Chris said. Justin, that was phenomenal. I was, like and I've said this to so many people, but I was, texting Chris behind the scenes, like how amazing that talk was. That was really great, and important, and a lot of things that I'm not sure if anyone else here on the panel or in the audience, but a lot of things I haven't thought about. I'm a primary care physician, and there's a lot of things there that open my eyes. So I appreciate your talk, honestly, really great. Um, I'm just going to talk really briefly. When I was developing this webinar with Chris, I kind of had a couple epiphany moments, literally on the phone with Chris, about myself, and I think Chris remembers that. but we've spoken a lot about a lot of different topics, and we were talking about, we talk often about things like ADHD and learning disabilities and whatnot as well. And I started recalling moments from when I was younger that I probably haven't thought of in quite a long time. And I was speaking to Chris, and I was like, Chris, I think I might have had some sort of learning, whether learning disability or struggle or maybe even ADHD. And I'm pretty sure Chris looked at it and said, yeah, I think you did. Uh, so, I'm going to share about that, but more so about what I experienced and what I felt because I was too young to know um, what I was possibly diagnosed with. And also, my mom's not around to tell me, so I don't know. Um, but when I was in elementary school, really early on, I would say it was probably around the third grade or so. Um, I I must have had some sort of learning difficulty. I don't know what exactly, but every day I started being taken out of class. I'd be in the middle of class with my friends, someone would come to the door, and I'd have to leave class and get extra help. And I don't know why. It wasn't an after school tutor or anything like that because it wasn't after school. And it was that's all I can recall about that. What I definitely recall is the shame and embarrassment that I felt. All my friends looking at me, staring at me as I walked out of the classroom, wondering why is Michael having to be taken out of class every day? And I felt so embarrassed that some days I knew roughly the time the person was going to come get me out of class, and I would hide under my desk and not want to be taken out, hoping they would think I was absent that day. And I shared the story because I feel that likely there are those out there with learning disabilities or ADHD or anyone who needs some sort of reasonable accommodation for their learning who may have experienced something like this, some sort of embarrassment or shame, because unfortunately, society still needs to catch up. Society still needs to change and better support those who are dealing with anything in that realm. Again, whether it's learning disabilities, ADHD, test taking anxiety, neurodivergence, anything that just is a bit different from someone else and maybe needs a bit of a different pathway. Um, and realizing that just needing a bit extra help is no different than someone who has asthma needing a nebulizer, right? Is no different than someone with high blood pressure needing medication to bring the blood pressure down, right? This is if you need help, and I've spoken about this often, you get the help that you need. And we need to destigmatize all of this, learning disabilities, ADHD, anything where, mental health, which I speak about often, it's something that you need help, you get the help that you need, and put yourself back on the right track. We all need certain tools, different than others, maybe more or less than others, and that's okay. We need to normalize that this is okay. And for anyone out there listening or will listen after to the recording, and if you did ever feel shame or embarrassment in a similar situation, know that I feel for you, but know that, again, it's okay because I got the help that I needed. And fast forward, I was valedictorian at my high school. I graduated, summa cum laude in college. I went to medical school and now I'm a doctor, right? So you can do anything as long as you're provided with the right tools. So I just wanted to share that. Uh, I thought it was important, but then I was kind of on the fence. Chris thought it was really important that I share. So I appreciate your support always, Chris,
Of
in
course.
those moments of doubt of mine. And I'm just so happy to be amongst friends and colleagues. So thank you.
Yes, thanks, Dr. Foti. I appreciate that. And as some of you don't may or may not know, Dr. Foti is one of the co-founders of Mind Split Cafe Med School Edition, and he has done great things with this and has catapulted much further than I could ever have imagined. So, Dr. Foti, thank you.
It's a team effort. Team effort.
So now we have a special guest. We have Monica. Monica actually has some really cool information she's going to share with you guys for a few minutes. And then we're going to get the panel discussion ready and start the panel discussion. I do see that we have some good questions coming in already for the Q&A part of it. By all means, if you guys want to start putting them in the chat, we'll have them ready for the Q&A. But Monica, you're up, ma'am.
Thank you, Chris, and thank you for allowing us to participate today. I believe you have a slide, right?
Yep.
Maybe. Okay.
Yes, ma'am.
All right.
Uh,
Well, let me introduce myself. My
there we
name is
go.
Monica Quintana. I am the National Director of Business Development for Empower Brokerage. Empower Brokerage has been around in the industry for over 40 years. And we specialize in high level enrollments when it comes to Medicare sales, life annuities, and ACA, which is also known as Obamacare. Across the country, we have currently have exclusive agreements with different hospital systems, provider groups, acquisition companies, accountable care organizations, direct contract entities, etc. Upon graduation, if there's any specific areas or markets, hospital systems that you're interested in, feel free to contact us to get you connected. So we have over 11,000 agents across the country. So if you're interested in building an independently owned practice, we can absolutely help with that. We get so many different types of leads from hospital systems and from carrier, like from the plans, that we're able to navigate, new patient growth. We also help with the patient retention programs. A lot of times when we have some partnerships with providers, we do patient appreciation events for them at no cost to the provider. We also have health fairs where we have a focus on quality metrics and preventative care at no cost to our providers. We get our carriers really engaged in helping the providers meet their metrics. We also can assist with the contracting process if you're going to build your own practice, regardless of its primary care, internal medicine, or specialty, or we can assist with the Medicare and Medicaid and the Obamacare carriers when it comes to the credentialing process. It's a little lengthy, so if you have any questions, you can always feel free to reach out to us and we can absolutely assist with that. Here, when COVID hit a few years ago, Medicaid applications were ongoing. And so last year we started to see that folks had to reapply in order to get accepted into Medicaid again. And it wasn't so much that they didn't qualify for it, but they didn't know the process. So we can absolutely help with the Medicaid process. Um, if you feel like you have, would like any type of healthcare reviews, I put a phone number on there that you can call. You can always reach out to me via email or my cell phone. But I do have a phone number that's designated for Obamacare products. And as you can, we always train the agents to do the best thing for anyone, whether they're over 65 or under 65. There's a certain assessment that we should always do on someone. And if it's for mental health coverage, there's absolutely specific carriers that cater to that. So without any obligation, we do our assessments 100% free, no cost to anyone calling to inquire about that. If you're interested in learning about personal or business investments and healthcare coverage, we have a free licensing class that we have available once a month across the country as well. So if anyone has any questions, feel free to reach out to me. We'd be more than willing to help you, whether you're a provider or whether you're a consumer looking for any type of healthcare coverage when it comes to mental health. Thank you so much, Chris, for allowing us to be here today.
Yes, thank you, Monica. I really appreciate it. And just as well with Justin, we're going to put this slide in the next newsletter as a resource packet. So everyone that has attended will get this as well. So now, what's next, Dr. Foti? Think we're going to get the panel discussion together. So we're going to take like a quick 2-minute break just so we can make sure we have all the questions ready. Again, feel free to put your questions in the chat for the live Q&A portion of it. We will get started with the panel discussion here in the next couple minutes. Right. I think we're ready to go if everyone's ready to come back.
I am ready. Are we ready? Are we ready, amazing panel? Your time has come.
All right,
Sip your
Dr. Fody,
coffee. Tell me.
I'm gonna let you go ahead and take the wheel on this one. I
Yeah,
will. I'll obviously ask questions as well. I'm just getting them pulled up, but I'm letting you take the wheel on this one, sir.
I got you. All
But
right.
I do want to say one thing. I wanted to give a shout out to Spain Sober Living. I just saw that they jumped on as attendees. He has two sober living houses in Austin, and it looks like both of them are on this webinar with all the residents. So I wanted to thank him for that. But Dr. Fody, go ahead.
Yes. So hello, attendees. Welcome back, and hello to our amazing panel. So again, remember, panelists, please feel free to chime in, as this is going to just be a group. And let's get started. The first question is, many adults struggle with focus and productivity. How can someone distinguish between normal, we'd say normal attention difficulties, right, versus clinical ADHD?
Well, I'd say one of the things to consider is the problem with attention significantly impacting your work? For example, are you getting written up at work because you're not paying attention, not turning in your projects, not getting things done on time? Those are one of the things to consider. How bad is it impacting your work? Or if you're a student at school, is it causing you to fail your courses, not turning things in on time?
Thank you, Dr. Amador.
Thank you. I think you muted yourself on the last part, Dr. Ramadan, but I appreciate it. That was a great answer.
Oh,
Anyone else want to chime in before we move to the next question? No? All right. To kind of shift over a little bit, but staying on the same topic, what would we say is the difference between either a learning disability, ADHD, or testing anxiety versus just struggling with certain subjects? At what point should someone seek professional evaluation?
I can speak on, can you all hear me?
Yes?
Yeah. Hey, Lisa.
Hey, I'm so outnumbered with all the men on the panel. That's all I see. This may not answer the question entirely, but I think it's something that I would love to share, something that I learned about me growing up in school and how it was difficult for me to sit still, to stay focused, comprehension. And this is something that I learned much later in life is, and I wasn't, diagnosed, although, the jury's still out, that if you are in a chaotic, kind of unpredictable environment at home in your formidable years, in those early years, the ability to concentrate, to comprehend, to stay focused is much more challenging because the brain is in that kind of fight or flight mode in those very early years. For any kind of inability to just sit, listen, comprehend, meaning mine as well. I lived in a chaotic environment, therefore, in the very, very early years, 1 to 7, that learning was more challenging. And whether or not I was diagnosed, I wasn't diagnosed back then, but whether or not I had the ADHD or ADD or whatever, that was not determined. I was just told you've got ants in your pants and you just need to stay focused. Well, 50 plus years later, I learned that it's because the environment that I was in was so unpredictable that the ability to focus was much harder than if someone was in a very nurturing kind of calm environment. So although that may not have answered the question, which I'm sure it didn't, I think it's important that people understand that if they're, if especially if they're learning more about their sobriety and recovery, that, if their education was difficult, even though they're still going on with their educational career, that has a lot to do with it. And whether or not you get the diagnosis, at least we have a foundation of maybe why it could be more difficult to stay focused and learn and comprehend is because of that. Was that helpful?
Yeah, yeah, that was.
I think it was.
Well, it really was
Oh.
very interesting to learn much later in life. And I knew nothing. I just thought, oh my gosh, I don't know how to comprehend. I don't know how to do this. And I did fine. I have a degree, all that stuff. But I didn't understand why everyone else around me was getting it quicker and retaining it. So
Can I add to that possible?
Yeah.
Awesome. Being a coach for 17 and a half years, being an ADHD all my life. Yeah, I wrote a book on my all my stumblings in my formal education. And what I found was it's kind of like when we're engaged in activities that we have no interest in, like ADHDers are our neurowiring is interest-based. However, that's baloney, because what I see in my clients when they're engaged in tasks, and you can blame your past, you can blame what happened when you were a kid, and that's in the hard drive, our neural, it's in our neuroanatomy, but you have discernment what thoughts you want to bring into the world, what thoughts you want to treat as, I always say, I never date a thought or marry a thought. I first look at the thought that's going through my head before I want to birth it into the world. But what I found was, and when I see through my clients, is that what we think of as something, we can't sit still for, we can't focus on, bills and other mundane things, especially for ADHDers, bills are historically been our thorn in our side, is the fact that once we see we're the manager of our thought factory, that we're the custodian of our thought factory, we don't have control of the thoughts that are coming into us, whether the thoughts from 50 years ago about how hard a chaotic environment we lived in, or thoughts right now that we're having. All of us are having this neural Netflix movie going on right now. As I'm speaking, you have a lot of noise up there, a lot of stuff clanking around out there in our brain. Is that when I got curious about how mind really works, about how we work as human beings, that I can still wash the dishes, pay bills, and be really curious about that moment-to-moment experience and start to enjoy it just by getting curious about it. Like I remember my first job, and I couldn't sit still in school. I mean, I barely got through my formative education, and it's amazing I graduated college or grad school. But what I saw is that when I see that I am not my thinking, that I have expansive thoughts, I have contracted thoughts, that what's really cool is that my system is designed perfectly. My mind feeling system designed perfectly to alert me to the fact what thoughts are serving my greater purpose, what thoughts are not, what thoughts are high quality, what thoughts are low quality. And that has everything to do with every manifestation of whether you have ADHD or you're on the spectrum or whatever you call it, peanut butter and jelly sandwich, it doesn't really matter. Whatever kind of brain you kind of have, that it is that easy. And it's just by seeing the illusory nature of thought that we're all living the experience of our thinking. And any moment we pop out of that and we get present as you're listening to my voice. So hope that.
Thanks, Sam. I also
Great
want
answer.
to chime in with some combination of what Lisa said and Sam. So when it came to what Lisa was saying, what really resonated was we can't learn unless we feel safe. And if we're not safe at home, and then that gets wired into our nervous system, it's gonna be really hard to feel safe. Even if you then are in an environment that seems safe, well, you're nervous, everyone else may feel safe in there, but you may not, because your nervous system has created a sensitivity to threat. And so I live with PTSD, and I get very frustrated because things are quite harder for me. And I've learned over time to have self-compassion. And when it comes to thoughts, I'm also a coach, and thought work has its place. It's important to know that when you are in a fight or flight or trauma response, your prefrontal cortex will go offline. It's very hard for you to think. So I want to honor that, because when people are like, well, let me just think, there's caveats to that. So when it comes to, one of the questions had to do with performance anxiety. Well, if you have a learning disability, you may develop performance anxiety. So if you're having struggles, a part of the question said when to ask for help. When you notice you're having struggles, that can help pinpoint what you need. And some things that's missed is the question that Lisa had mentioned, is like, are you safe at home? That was never asked to me. And it was a very important question that was missed, a screening question that was missed. Are you safe? Do you feel safe now? So I had very significant performance anxiety because I had grown up and the only thing that I felt love for was my achievements. And so therefore I put my worth in all of my accomplishments, which then turned into performance anxiety because I felt like my acceptance was on the line every time I took a test. And then if you have on top of that neurological differences, like I'm on the spectrum, well, it's very hard for me to take a test in an auditorium full of people that are like high anxiety because I'm just absorbing everything in there. So an accommodation I had was taking a test with a secretary, and I had so much judgment about that. But ultimately that helped me to just be able to calm my nervous system and I could think. So I just wanted to share with you as some of those may or may not apply. But I think the main question is, when should you get help? And it's if you notice you're struggling, and then what they can help you identify what things are contributing.
Thank you.
Yeah.
Does anyone else want to chime in before we go to the next question?
Yeah, I just want to add those were all great. Oh my goodness,
Yeah,
really great
absolutely.
stuff. Thank you.
So we'll switch it up. Now we'll ask a couple of substance use questions. And again, anyone can answer these. So what role does neuroscience play in addiction recovery?
Oh, that's my area. Hi guys, my name is Dr. Rob Kelly, specializing in neuroscience. I'm a PhD psychologist, PhD behavioral scientist, and behavioral expert. So we studied the neuroscience around addiction and alcoholism. And what we found was we know about neuroplasticity and how we can redirect and repattern the brain. But what we didn't know about, and this is 4 or 5 years, we're just doing the white paper for Kennedy right now, is the basal ganglia, the amygdala, and the hypothalamus role they play in alcoholism. We believe alcohol has 1% to do with alcoholism, same with any other addiction completely. Alcohol is 1% to do with alcoholism, is what we found. And alcohol is a born drug to me. So what alcoholics have is the predisposition with, especially the hypothalamus, which is our survival part of the brain. So what happens, the survival part of the brain and the temperature from the hypothalamus tells normal people to eat food, drink water to survive. That's it. At a certain point during my drinking career and every other real alcoholic, there's a real fine line. The hypothalamus turns around and tells me the survival part of the brain to drink alcohol to survive. And this is why A, it's a disease, B, you don't have any choice over it, and C, it's different than drug addiction. So when we look at the neuroscience, we look at the basal ganglia, which is tied straight to childhood trauma. Childhood trauma is the gateway drug, and alcoholics and addicts are more sensitive to the trauma. And this is what happens when we try. If we look at the epigenetics around the science that we've been studying, even at the fetal susceptibility level, we find out how alcoholism can be passed down. It may skip a generation or two, but I have an allergy. Well, we wanted to know, we've heard this in AA, but what is the allergy? But the allergy I have is to the ethanol in alcohol. So this trips off. Now, can we stop before we cross over to alcoholic drinking? Yeah, we believe we can. And we believe, which we'll get into later, that you can cure drug addiction, but you can't cure alcoholism, unfortunately, because of the predisposition in different parts of the brain instead. So very interesting. We started this about 9 years ago with the neuroscience, before it was called neuroscience. Just because when I suffered from alcoholism, I lost everything, including my children. I was homeless. I lost my medical practice. I lost cars, houses, everything back in the UK. I was homeless for almost 2 years. And nobody could tell me why. Nobody could tell me what alcoholism was. Well, just go to AA. Just stop drinking, Rob. I couldn't do that. So we aggressively dived into this area with the neuroscience. And what we found again is mind blowing. We have a 98% success with over 10,000 patients over 30 years. We're very, very strong on neuroplasticity and neuroscience pertaining to alcoholism, addiction, childhood trauma, depression, PTSD, and we're just doing new research on Alzheimer's and onset dementia. So it's exciting times. I love it.
Wow.
Great answer. I love your answers. They're very in depth and they're great. Thank you for that.
Yeah, Doc, you reminded me why I probably didn't do great in neuroscience and neuroanatomy in med school, but I think that that's stuff that I'm definitely going to be looking into after this, because it's as much as it's complex, it's very interesting. So thank you for sharing that. Definitely gonna look into this after.
We should talk, Dr. Foti. We'll definitely talk.
Please.
Yes.
Yeah, definitely. Yeah.
Does anyone else want to chime in on that one? All right. So I think another good question that kind of backdoors a little bit of what Dr. Kelly just went over is there's a lot of debate on whether addiction is the disease, a choice, or maybe even something in between. So the question is, what does science say, and what do you feel it is, and why?
Can I just quickly give my perspective on that just from a client experience? And so I worked in the recovery community for years down in Malibu. I'm in Santa Barbara, and working as a consultant, sharing this understanding that I share about how the mind works from the inside out, not from a neurophysiological perspective, but from a psychospiritual perspective. And I had a client who had so many DUIs. They literally, like, he's been in jail so many times. Like, he got his license taken away for good, and so that was that. And he was a chronic alcoholic. Like, he's been hospitalized more times. It was horrible. And so we were sitting down, and I asked him, and we were talking, I'm sharing with him the mind, thought, and consciousness, how we work as human beings, and this, that, and the other. And he said, he tried it on for size, and he was taking the bus and had some money in his pocket, and the bus passed by a liquor store. And he had this thought. It's like, I should stop by the liquor store and get a bottle of wine and go to the park and see my friend at the park. And he's like, wait a second. That thought doesn't feel great. That's a weird thought. I don't need to birth that thought into existence. I'm going to keep going. And he saw the light bulb went on. That you can, and again, this is not for everybody. Whatever works for people in recovery, it's a thought. We're all one thought away from not going and making a decision to go to a liquor store. And some people can say, well, it's not that simple, Sam. It's more complicated than that. There's a lot of other processes going on. I don't believe that at all. And I've seen that. I've worked with tons and tons of clients in recovery that sees like, oh, I have a lot of thoughts in my head during the day, 30,000, 50,000. Like, I have this feeling system built into me, alerting me to the quality of my thinking. If I have an anxious thought attached to, I need to get some alcohol in me, I need to go and get a bottle of booze, I know not to trust that thought. Oh my God. And I know those thoughts were going to settle, and they always settle. And for him, for my client, it saved his life. And he was able to be successful in his life and get a job and be able to be productive. And he still has lots of using thoughts. Like, we all have all kinds of thoughts that run through us. And for him, that was the paradigm shift. And he tried everything. And once he saw, like, oh, I'm the manager of my thought factory, and my thoughts are not mine, I know that I'm not gonna die if I have a real anxious thought or a real using thought to go out and get alcohol, that I'll be okay. You know, innately we're all okay. Our essential nature is well-being underneath the noise. That's who we are. And so like I was blown away by my client because like he saw it. It saved his life.
So if I may jump in, what we found around addiction as a whole is the epigenetics around addiction. We've tied food to addiction, definitely tried trauma to addiction. So when the neural pathways, and there are billions in the head, but 300 die every day, what are we replacing them with kind of thing? When the thought pattern will never come to me on Friday and go, hey, Rob, let's have a drink. It's a week before, at least, before my behavior starts changing. So we can capture, and again, you know, oh, Johnny around the corner, he drinks every day, he's an alcoholic. Alcoholism is the only self-diagnosed illness in the world. 20 DWIs do not make you an alcoholic. A warning from the doctor does not make you an alcoholic. It's what happens internally and psychologically when we have them. So look at the epigenetics around it, and then the genetic software, like I said, even at the fatal suspectability, then we're always meant to be this with imprinted cells. So if you look at the agouti mouse or mice testing that they did, is how easy it is to change patterns in the head pertaining to self-sabotage, or in this case, alcohol or drugs. If the patterns are not permanently changed, you will relapse, period. And this is what people have a hard time understanding. The basal ganglia is like a clock, guys, okay? And this is how alcoholics and drugs, this is why it's a disease tied to the hypothalamus. At 12 o'clock, we relapse. At 10 after, we come back all humble. At 20 after, the wife takes us back, half past, I move back into the house. At 22, I get that job interview. At 10 to, I absolutely destroy everything. And that's not even a choice. The question is, with the neuroscience, is why do I keep doing that? Well, that directly goes back to childhood trauma. Babies are born with two fears: the fear of falling and the fear of loud noise. The rest are man-made. And the food that we eat is all tied in to them decisions that we make about the disease. It's definitely, well, alcohol is definitely a disease because of the hypothalamus. Drug addiction is what we found. We can cure drug addiction, but it's all mindset. It's all changing patterns in the brain. If we don't change a pattern, it will always end up the same. That could be our environment, it could be our friends. Childhood trauma, when somebody does something here as an adult, it directly links to a childhood trauma that happened to you when you were young. And because we're more sensitive, it could be as little as obviously stupid. I was told when I was a child, you can't go to college like your brother, you're too stupid. That affected me for most of my life, because that is stored in the subconscious brain. And you know when that comes to fruition, the prefrontal cortex, just when I'm going for that job, just when I'm going to, it all comes out, and all the bad stuff for my father and everybody else, caregivers, comes to the prefrontal cortex, and that's my true belief. And that has to be stopped. If you don't go back and uncover, discover, discard of the trauma, you will always relapse. This is what our studies have shown. And it's interesting because everybody wants to concentrate on the alcohol. Everybody wants to concentrate. No, that's not the I have never had a drinking problem, guys. I had a thinking problem. So when I look at the medical side of it and the neuroscience side of it, it's blatantly what it tells us. It's more complicated. But I like what Sam said. It ain't rocket science if you know what you're dealing with. The problem is, if we went into High Street now and we pick 10 people and we go, hey, what's an alcoholic? They're going to say someone who drinks so much alcohol. That's not the case. The case is that I've had this disease since birth, or with the addictive personality with drug addicts, it becomes a working part of the mind. So the addiction starts in the basal ganglia, drug taking. 90% of people that come to us with drug addiction, heroin or cocaine started in the doctor's office. Not talking about you, Dr. Tulsi. But it goes round and round, it becomes a working part of the brain, and that's when drug addicts can't say no. They both present the same, but they're slightly different when it comes to the neuroscience and the medical industry.
I love it.
I think it generated actual electricity in the room. The minds that are going on here. Unbelievable. Sorry, Lisa, go ahead. Oh, you're muted, Lisa. Lisa, you're muted. Sorry.
I am
Thank
muted. I'm sure my
Good.
husband would appreciate that. No, just kidding. I think everyone kind of has their own idea of addiction being a disease and or not. I think a simple way for some to receive that is, you know, addiction definitely is a disease, and it can be boiled down to a choice if the relapse occurs, right? I think that when we're in active addiction, that disease is full force. We will have the disease. But if we are in recovery, to pick up that first drink as a relapse, I kind of believe that is where choice comes in. So do you see how it's kind of woven? Like, yes, it is a disease. And if you have some time under your belt, you know, the stinking thinking, that's when the thinking is, okay, I see it in front of me. Is it my choice? It is my choice. Am I going to pick it up or not pick it up? So that's a very simplistic way. I think the answer to all of that is so layered with explanation and how we look at it. But, you know, I personally believe it's a disease.
Thank you, Lisa. That was
I'd like
very
Yeah,
to
very
insightful.
good point.
I'd like to piggyback off what Dr. Kelly said. My name's Elizabeth. I'm a chemical dependency counselor as well as a clinical social worker. And my background stems from working with patients with end-stage renal disease and not having healthy coping skills, finding, you know, relief in alcohol or substances while dealing with dialysis. I do believe the science that I've read shows that addiction is a brain disease. And as it kind of evolves, it could be a gradual process. A lot of people are born with this allergy. I'm unapologetically 12 steps with my background. The same way somebody would have a peanut allergy, some people respond to alcohol and substances very similarly. And, you know, we're talking about the brain chemistry and how the structure and the functioning of it changes. But one thing that isn't looked at a lot is dopamine. More often than not, people are using because they don't want to feel or experience their feelings because they're negative or they're heavy. When we introduce any type of substance that suppresses that negative and allows us to feel some type of relief or pleasure or joy, we're getting a surplus of dopamine. Over time with the addiction process, your brain naturally no longer creates dopamine in a healthy way. And that's where that addiction starts to build. That's where the brain becomes compromised and that structure and development of it is compromised, especially for people that are under 25 and their brains aren't even fully developed. So essentially, they're getting rid of their natural ability to create dopamine, replacing it with substances, leading to a higher tolerance. And the hard part when it comes to recovery and the fear of relapse is because of this lack of dopamine. When people find themselves on the other side of recovery, which is incredible, they feel bored because that pleasure system, that excitement, that joy that they experience, they become numb to it. There's a deficiency. And so educating not only yourself, but your patients as you continue to move forward in this work is understanding that all of that negative and suppressed feeling, you're going to have to build that foundation and find those sparks of joy and create a new pleasure system without that substance when you're used to having hundreds, if not thousands, of hits of dopamine compared to the only like 40 or 50, I think it's like deciliters per milliliter or something like that. I'm tripping up on my words a little bit here, but you don't need very much to function. And when you're used to a surplus of dopamine because of alcohol and substances, it makes sober life feel very boring. And having to reframe how we think of day-to-day functioning and joy and excitement and a feeling of a life well lived, it's hard to recreate that narrative, especially with years, if not decades, of substance use and artificial dopamine. So I do believe that when we look at addiction, normalizing that it is a brain disease, because those chemicals, those substances completely alter the functioning and structure of our brains.
Elizabeth, that's brilliant. I love that. I absolutely adore that. I just want to put a quick note on that about the 4 chemicals every day, the dopamine, oxytocin, serotonin, and endorphin, is we need them for, obviously. But what a lot of people don't know is the main one, as you just said, the dopamine and the serotonin creates in the gut. So if we're not eating half decently, if we're eating all the rubbish that's in our food today, 90% of stuff is sprayed with cornstarch, and it's the first ingredient in any health bar that I've seen starts with canola oil, which is a seed oil. It's not good for us. So unless we're eating well, we're still not going to get as much dopamine as we can. Like Elizabeth said, it's not much, but we still need to be aware that, you know, the other two are here, but the other two neurotransmitters, they come from the stomach, or they are created in the stomach, in the gut. I'll be quiet now, I promise.
Thank you. Those were all great answers. And I have one more, and then I think we're going to kind of go to the learning disability side again. What are the most effective strategies individuals and communities can implement to prevent overdoses? And how can we make harm reduction resources more accessible to communities and individuals?
I could start this one off. Hi, my name's
Yeah,
thanks,
Tom.
Chris. Hey, my name's Tom McCary. I'm a mental health counselor, also a person in recovery and with ADHD. um, uh, so, you know, I think it's really all ties together, and a lot of it comes back to what Justin was talking about, you know, addressing stigma. You know, I think we all can work together, and it also kind of goes into the question that got asked in the chat about how can we support providers and reduce stigma in the healthcare setting. What zero overdose approach does is, you know, models some of the best evidence-based practices for suicide prevention. Basically, like, you know, we go to the doctor and they ask us questions about depression and suicide, right? This is like at a normal physical, or going to get our blood pressure checked or something like that. They ask, it's a routine universal screening for depression. And if that's positive, then there's follow-up. There's like a care pathway. And so, you know, raising the risk for overdose to the same, where we asking people questions about their substance use, and then addressing, regardless of meeting the criteria for having a diagnosis or not, but having things to offer and talk with people about harm reduction and overdose prevention, like co-prescribing Narcan, providing fentanyl test strips, and connecting people to the community. And so things that health centers can do is make this really accessible, friendly, visible, have signage, you know, ask us about fentanyl test strips, or, you know, have the providers say like, oh, I carry Narcan myself, right? Like, because this is a great community intervention. And so having a systemic approach that is a collaborative, whether it's an organization or a town or a county, that raises awareness and makes and prioritizes this in a positive way.
Great answer. Thank you, Tom. I appreciate that. Does anyone want to jump in on that one and tail or piggyback off anything?
Yeah,
You go first. Go on,
thank
Elizabeth.
you. One thing that I would like to add, my background, I worked with residents in a psychiatric unit. And one thing that, while they're in that process, they incorporated like SBIRT. So making sure, either as you're going through your education and journey, just normalizing, incorporating a screening tool, whether it's for alcohol, substances. If you're trying to implement that and kind of normalize that, if every practitioner met with a biopsychosocial approach, which you're addressing, you know, any resources, deficiencies, strengths-based approach is always going to be good, but making sure that you're screening, implementing a brief intervention, and then having referrals and treatment options. If you don't have any of those resources readily available as a provider, you know, networking, utilizing tools like this, reach out to Chris, see if he can help you with some of those things, because learning to be comfortable with asking these questions, it's no different than any medical question. And the more we start to normalize that, we're making space for people to come forward and the process of them trying to identify if they even have an issue. You know, I come from a predominantly Hispanic community. Not drinking alcohol is kind of viewed weirdly. It's frowned upon, or people just kind of don't understand if you don't drink. So there is that normalization in it, and not hesitating around or kind of avoiding those conversations, just making a little bit of space for it, because I believe the average for a woman to consume alcohol is like less than 1 drink a day. So if you're having 2 or 3 a couple of times a week, you know, that isn't very normal. And you start to develop a tolerance, and just kind of having those conversations earlier about alcohol and any substances that somebody might be misusing. And then also having the conversation of what it's going to look like whenever you are building that tolerance, because a lot of people don't have the conversation once the tolerance happens, like how much more are you drinking, or how much more are you using, because you learn to kind of function. So recognizing what things are being put off, if any, responsibilities, if we're starting to neglect certain things, start having those conversations and address it early on. When a patient comes to you, go through that expert screening and ask, has this affected how you function? Has there been any adverse side effects to you maintaining a household, taking care of your children? And just kind of doing like a full circle approach on how substances can affect the way people are running and maintaining their households.
Yeah, this is the one thing I wanted to say. It was kind of, thank you so much, guys. The 2 answers were great. Just a question from a resident here. One of the residents has a question: can we fully recover? I've been sold I will struggle rest of my life. First of all, that's BS. Whoever told you that has no idea how many people have been killed with that line. 100% you can recover. 100%. 100%. We offer money back guarantees. If you relapse when you leave us while following our program, I'll pay you the money back. 100%. Don't listen to anybody that says you can. They don't know what they're talking about. See, we listen to these people. Oh, you didn't get sick overnight, you can't get well. No, that's not true. Well, you can. Shut up. Says who? Well, you're going to struggle. Says who? So I'm looking at the source of who's telling me that. And they have no experience in alcohol and drug addiction. They go to meetings, they piss and moan, they want to be the Debbie Downers of the addiction world. Don't believe them. You can fully 100%. I have 9 years full of research and papers that tells us this. So that's the good news. I'm going bad news. It's awesome.
That was a great one, and you kind of broke up when you started that one. I think that was the question that came from one of the residents at Spain Sober Living, right?
Correct. Yes. Just feed it down.
Awesome.
All right. Thank you all.
Yeah. Dr. Fodi, or does anyone want to chime in on that? Or Dr. Fodi, do you have a question on the learning disability side?
Unless someone wants to chime in, yeah, I was going to shift over back to learning disability and ADHD.
I can want to see one thing.
Yeah.
So I was in the hospital when I was younger for anorexia. And one thing that stuck with me that really made it more challenging for me to get well was when someone said, I don't know why y'all are even here. You're just going to go back out and do the same thing anyways. And that fueled the eating disorder in my head. And so to believe that I could be someone who lives without being ruled by an eating disorder was very important. So I find it is important to grab on to the messages that we're here today that are more encouraging, because I do think that those comments that could be well-intended or just said out of fear or being tired can really have imprints in our brain that can create obstacles in recovery pathways.
Can I just add something real quick? Thank you, Dr. Rigart. Is it Rigart? Rigart. Yeah.
Rigart, yeah.
You know, I think we're all living from a space of psychological innocence. that we're all doing the best we can with the amount of thinking that we have on in the moment. And when clients, patients really understand what that means, from perspective is that we're, we're all living from the experience of our thinking, that it is psychologically innocent. We take those things less personal, even though we have a feeling system that's saying, no, that was a slight, that didn't feel good. And, someone like me, like Sam here, that was diagnosed ADHD, had ADHD all my life with the RSD stuff, rejection sensitive dysphoria stuff, which feels like the world's coming to an end. I have those feelings all the time. I have that feeling and I can pinpoint it's in my solar plexus. I know it's not true because the feeling's too strong. And once we teach clients that our feelings are alerting us to the fact of high fidelity or low fidelity our thinking is in the moment. Like our feeling system is not there to punish us, even though it sucks sometimes. We've all been in those experiences when we've had tremendous thought storms, but Sam has thought storms all the times, but it's not like prime time news in Samville when he's got a thought storm moving on through. I mean, so like as clinicians, as therapists, as educators, as professionals in your field, which you guys are beautifully doing and transforming your clients' lives and yourself, because it comes from yourself first. It's being aware of where that's all coming from. A thought, nothing more, nothing less, attached to a feeling. And yes, it is that simple. Our intellect overcomplicates it. We have theories and scientific processes and, theorems and diagrams and papers. And, I could never go to medical school because it was like my head would explode. But we're overcomplicating things, I think, from where I'm sitting as someone who was misdiagnosed 27 times, has been on every kind of, from my perspective, working with people from all walks of life, like all of you have, with all kinds of diagnoses, with all kinds of addiction issues, until they're not. We're overcomplicating very innocently what you just shared, and it's initially when I heard that, what I'm just sharing with you for the first time, I'm like, come on, it's not that simple. I've suffered for this amount of time. Look at my trauma. Until I really said, oh, wait a second, I'm making that up. It's an illusion and it feels real. And I know a lot of people are gonna be like, maybe not. It's in my hard drive already. I'm just spewing it out because my hard drive's hitting play. And now I have this Technicolor Netflix neuro movie of my experience. And I've seen amazing things that happen when we start taking our hand off our thinking. Kind of like when we're kids, we learn not to touch the hot stove, right? We do this with our thinking and it hurts, and we'll still keep doing it. We're like, why am I doing that? And that applies to anything. But our intellect and our ego is going to play a game with us, and then it becomes a Stephen King novel in our head. So I'll leave it at that.
Oh, unbelievable. So cool. So interesting. I have a thought storm right now, Sam, and I'm gonna try not to chase it.
I have those all the time.
Oh yeah. Oh yeah. Yeah, yeah. Sam, I'm gonna be calling you up one day for your services for sure. Amazing. So I'm gonna shift it over. We have a few minutes. One last question. Um, to round out the learning disability and ADHD side of things. I think we had a really amazing discussion. Don't you think, Chris? I think this was really good.
Yeah,
Uh,
it's been phenomenal.
yeah.
And we
So
we
one
still
last,
have a few
yeah,
questions after we're finished with this. We have a
yeah,
few questions from the group or from the
yes,
attendees that we'll be throwing out there as well.
yes. Please stick around. We're going to be answering those in just a second. The Q&A question. So one last question being, medical school is an intense, high stakes environment. So how do ADHD, learning disabilities, and test-taking anxiety specifically impact students in these high-pressure academic settings? How can they navigate these challenges?
think, didn't Dr. Reich, am I saying your name right? Dr. Reichert? Am I, you kind of touched on that about how you were taking tests, and I, although never in med school, I was also placed in a different setting to take tests in a certain part of my educational career. But I'm not trying to put words into your mouth, but I think you really did a great job explaining your personal experience, and that kind of flows into this question.
Yeah, I think in med school, with the fact that there's so much pressure put on performance, that actually increases your performance anxiety because you're attached to the outcome. So that's where perfectionism becomes maladaptive. And where my own test anxiety was created was because I was trying to control more of my grade, the outcome, focused on that, and it deviated from focusing on what I could control, which was my studying and taking each question. And anytime I didn't know a question, it would make my anxiety go sky high because it was an all or nothing thinking. So in test performance, really understanding what's escalating. Sam talks a lot about thoughts. That's one thing, is considering, where are your thoughts? I thought I would be a failure if I got a certain grade, like a, whatever, on a test, or I was less than if I performed worse than other people, which is constantly reinforced by the academic environment. And then if you have a disability or a learning difference, then if you have shame attached to that, then shame can put you into a physiologic overdrive where then it's even harder to think. And that can just really escalate some of the challenges and lead to worse performance. So perfectionism and test anxiety can paradoxically lead to worsening performance. So I really think it's understanding your contributing factors and what you're making it mean about your test scores. And if we can detach our worth or whatever you're making that mean from the test score and focus on what you can control. For me, that really supported me in being able to manage my own anxiety. And if you can manage your own anxiety and learn to regulate it during your test so you can support your brain with that short-term memory, then you end up performing better. But in the moment, it's like, I think preparing outside of the actual test day is important, so you have those skills and tools, and there's a lot of self-awareness that can come into learning why you have test anxiety and how to best support yourself. And then of course the accommodations that Lisa was saying, like if you're noticing that you do, some people get accommodations to have more time on tests, and me, it was like have less time on tests because I would overthink things, and then be in a quiet environment.
I have a client that's actually, sorry, I have a client that's actually in medical school right now. and sorry, I didn't mean to interrupt you, Dr. Amador, but just, and I asked her the question, I said, tell me when you know just how to do things. I mean, I'm trying to break everything that's down simplistically. Tell me how you got into med school. Tell me how you took chemistry tests. You're in med school now. You must have done something right. Tell me how you got into the flow state. Because when we're present and when we are present to what is in the moment, we just know how to do things. It's called common sense. Like we learn a rhythm to test it, to testing. We learn a rhythm to getting accommodations if we need it. We just know how to do things. All of y'all, those of you that are doctors that have brain that works differently, like my brain, my Technicolor ADHD neurodiverse brain works differently. I just learned how to do stuff, but I didn't have to think about it so much. I just did stuff. And my client who's in medical school right now, like it wasn't the studying and the rigorousness of the program that got him in trouble. It wasn't his test taking, it was his thinking about it. And his relationship to his thinking about oh my God, it's med school, it's stress and competition and no sleep and bad diet and it's endless what our intellect creates and makes up. They're all, little Netflix movies, I call them, creating a fear and loathing in Las Vegas situation in our head. And when he saw that, it's like, oh yeah, I'm making a lot of this stress up in my head. And he tried, and he's doing amazing. And she's doing amazing right now because she stopped paying attention so much to the haunted house, the house of horrors in her head about the medical school experience. And the other thing that helps is put down like social media and listening to the other horror stories that people are sharing in their other students that are having problems. And a lot of people see that and they get present and they're able to do med school and to do life. And if it's and again, it's hard for the intellect to hear this because the intellect wants results. It has to connect the dots and fill in the blanks. Our neurophysiology does that because it wants to keep us alive. The brain's sole mission is to keep us from dying. So it's going to do a lot of nutty stuff to keep us alive. Well, there's something else besides our brain that's running the show, ladies and gentlemen, that we don't even know. So if it's in the cards, it's in the cards. But our intellect doesn't want to hear that. So sorry. Hope I didn't talk too much.
No, that was great. I love the way you answered the questions. You're able to like explain it to where people can understand it in different ways. So I love the way you answer questions. Dr. Amador, I think you wanted to chime in.
Well, thanks. I was going to say one important thing for us to consider too is as educators, right? Whether you're an attending physician or you're working, with the medical students in a different capacity or the residents in a different capacity, it's important to let them know that, hey, you know what? Sometimes we won't have the answer to things because sometimes the medical students and the residents feel that they need to have all the answers, and we can't always have the answer. The important thing is that we need to know when to ask for help and who to turn to for that help. So I think that's something that the medical students sometimes are like, oh, I gotta be perfect in everything, when that's not possible. And that adds to that test taking anxiety, like Dr. Reigert was mentioning.
So true, Dr. Amador. So true. All right, Chris, should we move on? We have a good amount of Q&A questions from our audience. I think we should start tackling those.
Yeah, we do. Let's start back. We got one early on, so we'll start with that one. Where'd it go?
I believe it
So
was early on in the chat. Yeah.
yeah, we got two of them right off the bat. So what are the best ways to support providers so they feel comfortable treating substance use disorder in primary care? What are the best strategies in beating back workplace stigma, conscious and unconscious? It was kind of a two-part question, but that was the first one that was asked. And anyone can answer this one. Just chime in.
I can do the stigma, workplace stigma. It's important for us, I think, when we have thought about what other people are thinking about us, it's oftentimes filtered through our own lens. So if I'm feeling a certain way about accommodations, then I'm going to think everyone here is thinking something about my accommodations that may or may not be accurate. And if someone is saying something to us, judging us, it's one going to be filtered through their own biases, and it might be considering how your accommodations impact them. So if for me, what's been really important is to just develop my own relationship with my own accommodations and reduce the self-stigma, and then accept that people are going to say certain things. Just like anything, people will judge us for anything, and at times it can deter us from speaking up and getting the accommodations that we need. So just learning to stand up and advocate for ourselves and just know our own truth and what we need. And sometimes it's just getting comfortable with people having a lot of thoughts about us, but really self-compassion and developing a relationship with yourself is probably the most stable self-protective thing.
It's a great answer. And I can
Yeah.
piggyback on it in terms of how to support providers in becoming more comfortable talking with clients about substance use issues is in effect to make it integrated care. So having peers involved in the primary care setting, having behavioral health, psychiatry involved, highlighting champions. There are people with more expertise, highlighting them, but not just funneling anyone. Oh, you have a substance use problem. That means you see Dr. Whoever, right? It's that person's an expert so that they can share the information that this doesn't, because that actually further, sometimes specialists can kind of like further make into silos, like, oh, I do primary care and that person does primary care with substance use. The end of it is that like you're not seeing special people. It's part of the care that you're working. It's not those people with substance use. It's our patients of the clinic, many of which have various histories and experiences with substances. So it's making it similar to all of the other health issues that providers work with, normalizing it in an effect. And then also, providing specialized treatment, specialized brief ways of getting training, and having, even things like warm lines, making it really easy to get support when needed.
I
Chris, if
think
you don't
too,
mind, I'd love to. I'm so sorry, Lisa. I want to ask Tom a real quick question, and Lisa, I want to get to you. I want to hear your answer as well. Um, to piggyback off of that, Tom, so coming from a primary care provider, look, I can attest working in as a primary care provider, most of us don't feel super comfortable, right, in that realm of managing substance use disorder. And so do you think that in most, if not all, primary care facilities, right, so medical groups or private practice, there should be a member of the team who is experienced in managing substance use disorder and being able so they can more closely work one-on-one with the primary care provider instead of saying, oh, well, here's a list of places you can go, right? Having someone be a direct member of the team. How do you feel about that?
Yeah, well, I think there needs to be more training in medical school, so that
Yes.
people feel more comfortable coming into the field. There's also additional ways of supporting. There's like echo programs. So it doesn't necessarily have to be somebody on site, but ways that the providers can tap into more expertise. And then it's also, knowing within like the screening, brief intervention, referral to treatment, it's also like just because somebody has a substance use issue, they're coming to you for all of their health issues. So you're still working with the person who, in addition to that, has substance use issues, right? So it's like you're treating the person. And if the substance use is what needing like specialized care, then it's thinking about types of referrals, but then also the type of things that can happen on site, like medications for opioid use disorder, for instance, is a gold standard in treating that. So things like buprenorphine, right?
Right. Thank you, Tom.
That's great.
well, I was going to say something really quick, Dr. Fauci. I think that was a really cool thing for you to say. Would it be, and I may not say it exactly the way that you did, but, having someone on staff that has had experience in addiction and recovery, it's very parallel to a therapist. I would not go to a therapist unless they specialize in addiction therapy, like to have some relatability based on personal experience. And, in a perfect world, if we could have every kind of resource on staff, right? I'm not a doctor, but I am a recovery coach and a life coach, but providing information to these patients and not just a card and not just a brochure, but knowing the people that you could potentially refer them to, again, whether it's a counselor or an addiction specialist or a recovery coach or sober coach, knowing them personally, getting a feel for them, and hopefully being able to direct the patient with the right resource. But I think having some relationship with those resources, knowing them, not just here's a brochure, right? And then listening with intent to the patient, their needs, and hopefully being able to guide them in the right direction. But yeah, I think again, I'm not a doctor, but I think that was a really great thing to say, Dr. Valley, that someone with a background in it would most definitely make a patient feel seen and heard, and establish a relatable kind of experience and relationship.
Thank you, Lisa. Thank you so much. Chris, what's next on the docket from our Q&A?
All right. We have, let me go up to these just so we can answer them all. Okay. Okay, what resources are best to support staff that have substance use working in the medical and behavioral health field? So what resources are the best to support staff members that have a substance use disorder working in the medical field or behavioral health field? I think it was worded a little differently, but I think that's kind of what it was.
Some employers have employee assistant programs that are anonymous, right? That you could go to. Also, some of the medical boards, right? They have some programs for physicians, clinicians, if they need assistance with substance use concerns.
Thank you, Dr. Amador.
Yeah, thank you.
What's next, Chris?
We have another one. So why can't I focus? I don't have a diagnosis of ADD or ADHD. That's a good one. I think that's a very broad question because there probably could be a lot of things, but I'd be interested to see how this is answered.
I think you answered it correctly. If that was, we can't give generalized medical advice, right? So I think this would take understanding the individual and understanding exactly what's going on for them. So I think it is a question that could have multiple different answers, and that those answers will be unique to the individual.
That's a great response.
But a good question to ask, right? A good question to keep asking. But ask somebody who you're working with directly, who knows you.
Yeah, absolutely. Let's see, another one we have. I just saw this one come in. How can we help friends stay away from overdose but won't stop using?
I was looking forward to this question. I saw it, and and I want to give a shout out to the Spain Sober Living. All of which I think, a lot of what we're talking about is like pretty heady stuff, and like y'all it's all in service of you, right? Like people first, right? Like we can talk about neuroscience and all this other stuff, but nothing is without you. So I'm so glad that y'all are here tonight and using the chat and asking questions, because that's really what it's in service, what we are in service of. How do I help a friend not have an overdose, right? Like that's terrifying. So there's a lot of things that you can do. One, continue to try to support them, making steps safer steps, right? And that can be things like having Narcan, testing the drugs for fentanyl, not using alone. Not using alone is one of the biggest risk factors for having a fatal overdose because nobody's there in order to intervene. So there's a very different question, right? Like, how do I help someone not die from an overdose is different than helping them to necessarily get help, right? Well, you're asking, and I think that's really important, right? Like, I believe strongly in recovery, but that's only accessible to people who are alive. So there's things that we can do to support people who are using drugs, to help them be safer and healthier at that time. And so looking into what types of harm reduction programs might be in your community, but continuing to, be their, be their friend, and let them know that you care about them. And also, some very concrete things like using less over a longer period of time, using safer methods that don't that are less likely to lead to an overdose, and then having Narcan is really key, and having other people in their circle, have Narcan and know how to use it.
I love that answer. That was great. That is what Tom does. He lives and breathes this, and I absolutely love it. If you guys don't know, he's the co-founder and CEO of Zero Overdose. So I thank you very much for being here, Tom. I love your answers.
So glad that question came up.
So it looks like, unless a couple last minute ones come in, we have two more questions. And one of them, if Monica, are you still on? Okay, I don't think she's on. I will ask the question and then I'll let Monica answer it in an email. We'll put it in the resources. It's a good question. Can I be an agent with a background? I have a couple arrests. So it's a really good question. Monica's brokerage does deal with things like this, so I will get that answered for whoever asked that. I will get with Mr. Lawrence, who is the owner of Spain Sober Living, and figure out who directly asked that question, and I'll get that answer for you. And the last one, where to go? I just saw it. 1 second, I apologize. Okay. What is ADHD? Like, break it down in simple terms. That's a good question too. Wish I could answer that one.
Why can't you?
I'm not qualified, nor do I know.
Same. That's
I have a shirt that says undiagnosed, but something is definitely wrong. I feel like I do have some form of a learning disability. I can never focus, but I am definitely not qualified to answer that
I
question.
think Dr. Amador was going to chime in. Or am I wrong, Dr. Amador?
Yes. So not an easy question to answer, and the reason would be for a lot of things that are in our DSM-5 TR, which is a psychiatric diagnostic manual. A lot of the diagnoses that we have are based on expert consensus, meaning that from the DSM-5 aspect, many world experts got together and decided that, hey, if you have 6 out of 9 symptoms in the inattentive realm, in the hyperactive realm, that's going to help us, say, hey, your situation best fits inattentive type of ADHD, hyperactive, or combined type. But I'd tell you the best way maybe to think about it is the level of impairment, right? If you are somebody that, hey, you know what, I have a lot of inattentive symptoms, I can't focus, I can't turn into my work on time, I get easily distracted, but maybe you don't have the other, symptoms, all the number of symptoms of ADHD, that doesn't mean that you wouldn't benefit from treatment. You would just have to talk with your doctor, your clinician about what are some steps they can do to help treat you. So I hope I answered your question by saying that it's not an easy question to answer since a lot of these things are based on expert consensus.
That is a
Thank you.
great answer.
Does anyone else want to chime in on that last one?
Ditto. Whatever. Sure.
Yeah, and I
It is
love
a hard
that.
one to answer.
I love that Dr. Amador's answer and many answers that were given today by all of our panelists. I think a central theme on many answers was individualized care, right? So there's a lot of guidelines out there, but at the end of the day, it's people taking care of people. The whole holistic plan of care, taking care of you on many levels, right? So, and that's what this webinar is all about. We wanted to bring people in and try to give you as much information as our wonderful colleagues and friends can provide to you. So you can then go and take care of yourself.
Very well said, Dr. Foti. I want to again thank everyone for being a part of this. Our panelists, thank you very much for your time, your insights, and your knowledge. To the attendees, thank you for being interactive and engaging with us. There were some very good questions out there. Please continue to come back, continue to ask these questions. And we will be sending out a kind of after event resource packet. It'll be in the form of an email. It'll be somewhat of like a newsletter, and it'll have some of these questions broken down with more resources that you guys can utilize. And again, back to the panelists, if you guys have any resources you would like to include in this email, please let Dr. Foti or I know, and we'll put
Yeah.
them in there for them.
And Chris, if any of our audience want to reach out with any follow-up questions or just feedback on the webinar, is there going to be an email there on that packet where they can contact us?
Yeah, there will be, and I will go ahead and give an email out right now, just in case anything comes up between now and when they get that newsletter. It's going to be Nancy@mindsplit.org, NACY@mindsplit.org. You can ask any questions there. The newsletter will also come from Nancy@mindsplit.org. Dr. Foti, do you have anything else you want to add, or any panelists? Do you guys have anything you'd like to add?
I just want to say thank you to our panel, first and foremost. It was unbelievable, especially those I'm meeting the first time today. Really, thank you so much. And those who attended, thank you so much for being here. Everyone who's listening, please provide your feedback. Again, that's Nancy@mindsplit.org. We'd love to hear from you because this is going to inform future events, and we're going to keep doing things like this. So just stay in touch, subscribe, and we're going to keep bringing more of these events your way. I'm sure you'll see some repeat panelists because these are just amazing people. Yeah, thank you, everyone.
Thank you, guys.
Thank you.
Take good care.